Hello everyone and welcome to our Cancer Prevention Journal Club video presentation. My team member consists of me, Wong Yong Le, Siti Sarah and Zafira. The title of our Cancer Prevention Journal Club video presentation is Prostate Cancer Screening Patterns Among Sexual and Gender Minority Individuals. This article was written by 7 authors. The authors of this study are Sunchuma, Oluwada Milola T. Oradalu, Katie Wang, Christopher Edward, Anurag Kasim, Daphne A. Haas-Kroken, and lastly, Paula M. Dera.
Today I'm going to talk about a study that looked at PSA screening in LGBT communities. PSA stands for prostate-specific antigen, and the screening helps check for prostate cancer. The study included 164,370 people and found two main points. First, gay and bisexual men were more likely to get tested for prostate cancer and talk with their doctors about the pros and cons of screening. Second, transgender individuals, however, were less likely to get tested or make informed decisions about screening. These results show that we need better guidelines and more support for prostate cancer screening, especially for transgender people, to make sure everyone gets the care they need. I will introduce a study about prostate cancer and PSA screening in LGBT communities. First, it's important to know that prostate cancer is the second leading cause of cancer-related death in men in the US. About 1 in 6 gay and bisexual men face this risk. This study looks at how LGBT individuals participate in PSA screening and make decisions about it. PSA screening is a test that helps detect prostate cancer early. The study used data from the Behavioral Risk Factor Surveillance System and found differences in how often LGBT individuals get screened and how they make decisions about it. These findings show that there are important gaps in care that need to be addressed. Now, I'll talk about why prostate cancer screening is so important, especially for sexual and gender minority individuals. First, early detection for better outcomes. Screening methods like the PSA test can help detect prostate cancer early. When caught early, it's much easier to treat, which can save lives and reduce cancer progressions and death. Second, reducing health disparities. Unfortunately, many sexual and gender minority individuals face challenges in accessing the healthcare, like stigma, discriminations, or doctors not understanding their needs. Proactive screening programs can help close this gap and ensure everyone has access to cancer prevention services. Third, promoting awareness and healthy habits. Screening also starts important conversations about prostate health and cancer risk. It helps people understand their health better and encourage them to take steps to stay healthy. Prostate cancer screening is a vital tool in cancer prevention, especially for communities that often face barriers to care. By improving access and raising awareness, we can make a big difference in saving lives.
To address the knowledge gap related to the patterns of prostate-specific antigens, PSA screening in the LGBT population, a cross-sectional study was conducted with a weighted estimate of more than 1 million individuals of gender or sexual minorities in the USA. Data from the annual surveys of Behavioral Risk Factor Surveillance System from the year of 2014 until 2016 and the year 2018 were used, as this year's surveys included questions on PSA screening. Participants with a history of prostate cancer were excluded. Besides that, the primary endpoints of this study were PSA screening patterns, reported discussion of the advantages and disadvantages of PSA screening, which is a surrogate for informed decision-making and shared decision-making. The baseline characteristics of the study were age, insurance, race, ethnicity, comorbidity, education, income, geographical region, and smoking history. In addition, multivariable logistic regression was performed to evaluate both the association of LGBT status with primary endpoints and the independent association of LGBT status with cancer screening and healthcare access. All analyses were performed using SAS version 9.4 and R version 3.6.1. There were a total number of 164,370 participants that met the study criteria based on sexuality and gender reported, with a number of 156,548 cisgender straight, 292 male to female transgender, 3,354 cisgender gay, 1,641 cisgender bisexual, and 2,535 cisgender other sexual orientation. Now, moving on to the result. It is divided into participation in PSA screening and participation in informed and safe decision-making stratified by gender and sexual minority cohort, with each as its own subgroup. Participation in PSA screening stratified by gender and sexual minority cohort has two subgroups, which are PSA within 2 years and ever had PSA. All the results are compared with cisgender straight participants, with odd ratio higher than 1 is more likely than cisgender straight, while odd ratio lower than 1 is less likely than cisgender straight. Based on figure 1, cisgender other has an odd ratio of 0.2 with 95% confidence interval of 0.82 to 0.83. Cisgender bisexual with an odd ratio of 1.06 with 95% confidence interval of 1.05 to 1.07. Cisgender gay has odd ratio of 1.07 with 95% confidence interval of 1.06 to 1.08, and transgender odd ratio of 0.23 with 95% confidence interval of 0.22 to 0.24. It showed that cisgender gay and cisgender bisexual participants were more likely to have undertaken PSA screening within 2 years compared to cisgender straight participants. Based on figure 2, cisgender others has an odd ratio of 0.80 with 95% confidence interval of 0.80 to 0.81. Cisgender bisexual has odd ratio of 1.13 with 95% confidence interval of 1.12 to 1.14. Cisgender gay odd ratio of 1.29 with 95% confidence interval of 1.28 to 1.30, and transgender with odd ratio of 0.17 and 95% confidence interval of 0.16 to 0.17. It showed that cisgender bisexual and cisgender gay participants were more likely to have ever undergone PSA screening compared to cisgender straight participants. Both figures shows that both cisgender other and transgender group were less likely to undergo PSA screening compared to cisgender straight participants. This slide shows the participation in informed and shared decision-making stratified by gender and sexual minority cohort. It has 3 subgroups, which are informed decision, shared decision, and doctor-recommended PSA. Based on figure 3, cisgender other has an odd ratio of 0.80 with 95% confidence interval of 0.79 to 0.82. Cisgender bisexual odd ratio of 0.90 with 95% confidence interval of 0.88 to 0.92. Cisgender gay has odd ratio of 1.10 with 95% confidence interval of 1.08 to 1.11, and transgender with odd ratio of 0.35 and 95% confidence interval of 0.33 to 0.38. It showed that cisgender gay participants were more likely to have an informed decision, while other groups were less likely to do so compared to cisgender straight participants. Based on figure 4, cisgender other has an odd ratio of 1.07 with 95% confidence interval of 0.88 to 1.30. Cisgender bisexual has an odd ratio of 0.84 with 95% confidence interval of 0.66 to 1.07. Cisgender gay odd ratio of 2.55 with 95% confidence interval of 2.31 to 2.82, and transgender with odd ratio of less than 0.01 and 95% confidence interval of less than 0.01 to infinity. It showed that cisgender other and cisgender gay participants were more likely to engage in shared decision-making, while there was no association for the other groups compared to cisgender straight participants. This slide shows the subgroup of doctor-recommended PSA. Based on figure 5, cisgender other has an odd ratio of 0.80 with 95% confidence interval of 0.80 to 0.81. Cisgender bisexual has an odd ratio of 1.16 with 95% confidence interval of 1.15 to 1.17. Cisgender gay has odd ratio of 1.15 with 95% confidence interval of 1.14 to 1.16, and transgender with odd ratio of 0.19 and 95% confidence interval of 0.18 to 0.20. It showed that both cisgender, bisexual, and gay participants were more likely to have been recommended PSA screening by their doctors, while cisgender other and transgender participants were less likely to be recommended PSA screening compared to cisgender straight participants.
Now, let's move into the discussion. Focusing on the implications of this study for cancer prevention, one of the most critical implications highlighted by this study is the urgent need for tailored prostate cancer screening guidelines that are inclusive of sexual and gender minority populations. Current screening procedures fail to address the specific needs and risks faced by these groups, particularly transgender individuals. Despite undergoing hormonal or surgical transitions, transgender women may still retain prostate cancer risks. This gap in current practices underscores a pressing need to create inclusive and specialized guidelines to ensure equitable care for all. Another significant finding is the influence of clinician recommendations on screening participation. The study shows that cisgender, gay, and bisexual men are much more likely to engage in PSA screening when it is recommended by their healthcare providers. This suggests that educating clinicians about the unique health risks faced by SCM populations could play a vital role in increasing screening rates across the board. Improved provider awareness could bridge the gap in access and engagement, benefiting these underserved communities. For the next discussion, significance of findings and contribution to knowledge. For the first point, addressing knowledge gaps and highlighting disparities. This study is one of the largest investigations into prostate cancer screening patterns among SGM populations, and it provides solid evidence of the disparities that exist. While cisgender, gay, and bisexual men reported higher participation in PSA screening and shared decision-making, transgender individuals were found to engage far less. This disparity highlights significant barriers within our healthcare system that limit preventive care access for some of the most vulnerable groups. Thus, by shedding light on these issues, the study addresses a critical gap in our understanding and lays the foundation for future research and policy improvements. Next, for the point 2, advancing understanding of risk factors. The finding also deepened our understanding of the risk factors associated with prostate cancer in SGM populations. Cisgender gay men, for example, may demonstrate a greater awareness of prostate cancer's risk due to better access to healthcare and closer engagement with their clinicians. However, for transgender communities, systemic barriers such as discrimination and a lack of specialized healthcare options remain persistent challenges. These findings highlight the importance of addressing both structural and individual factors to improve outcomes for all SGM individuals. On the other hand, transgender individuals are significantly underserved, which reflects systemic inequities in healthcare delivery. These findings demonstrate the urgent need for inclusive screening guidelines, improved clinician education, and targeted interventions to bridge these gaps in care. To conclude, this study underscores significant disparities in prostate cancer screening behaviors among SEM populations, offering valuable insight for both healthcare providers and policymakers. The study reveals that prostate cancer screening behaviors vary greatly among SEM groups. Cisgender, gay, and bisexual men are more likely to participate in PSA screening and engage in shared decision-making, highlighting proactive health behavior in these groups. Now, what can I say for further possible next steps or areas for future research? We can study more in wide areas such as impact of hormone therapy on prostate cancer risk, role of HIV and other comorbidities and prostate cancer progression, implementation of shared decision-making models, social determinants of health. In summary, while this research provides critical insight, it also calls for action to ensure that no population is left behind in the fight against prostate cancer. Thank you for listening to us.